So I thank the organizers for this wonderful meeting. We have lovely discussions, and both here and at dinner at coffee time. So I'll definitely be back in 2 years, hopefully. Yesterday I talked about flicker photometry, which is not my field of view, and today I want to share with you some thoughts about inflammation, which is also something new for me, because I'm being a physicist coming from solid state physics, and I went to ophthalmology. And in methodology, doing it reflectance and macular pigment measurements. So, but I'm not an immunologist, so I hope that I can share with you some thoughts and some experiments we did in lutein and inflammation. So let me talk you through and show why we think there's more than blue light damage and antioxidant that macular pigment is all about. I have no commercial relationship. So let me talk about macular pigment. As you all know, it's where's the pointer? It absorbs bluish light, and as Billy Hammond has shown beautifully in many experiments, that this has some functional benefit, having a blue light filter in. But if you think of diseases, then there's more to it. That's not the blue light filtering options. But for instance, if you look at this is A2E. If you have A2E, which is a byproduct, it's in lipofuscin. If blue light is in this neighborhood of A2E, you get all kinds of oxidative problems, which are very harmful. So you better have a blue light filter in front of it to get rid of these harmful effects. So that's the blue light filter hypothesis of AMD. And then, of course, there's the antioxidant properties it has. This is DHA, which is bonded in the outer segments of the photoreceptors. And as we have learned during this conference, the zeaxanthin and lutein, zeaxanthin is stacked because of their structure in the outer segments of the photoreceptors, where it has this antioxidant properties, and it can take care that the oxidation of DHA is prevented. A beautiful instrument from Sunderland and the group showed that in vitro, that if you look at autofluorescence, which is a measure of this lipofuscin formation, it can be decreased by having either lutein or zeaxanthin in. So this is it really works as an antioxidant at the site where you want it to be. However, there is another aspect of lutein which has not been addressed yet. Happily for me, so I can have a talk which hopefully is of some interest. That's the inflammatory aspect. So I want to share with you some results from others. First, this is endotoxin-induced uveitis. If you induce uveitis by endotoxin, then you get inflammatory response. This is the number of infiltrations in the vitreous and the protein concentration in the vitreous, and it goes up by this LPS, which is endotoxin. But you can decrease this number by adding lutein, and it is as effective in high doses as dexamethasone, which is an anti-inflammatory drug. So it works really as an anti-inflammatory agent, this lutein. Another experiment has been done recently. It's looking at choroidal neovascularization, and the index of the volume is also influenced by lutein, as you see here. And if you then look for inflammation markers which go along with this process, then indeed you see that this These inflammation markers, they can be diminished by adding lutein. So that's probably the way this CNV is diminished. So there are some other hints that point to the anti-inflammatory effect of lutein. This, for instance, it's a Dutch group which looked at serum carotenoids in relation to endothelial function and inflammation. And what they found was the following. They found a lower by age-adjusted, a multivariate adjusted effect of lutein on the inflammation markers and on endothelial function, as you see here. And finally, I have to show you some results of Jonas Seddon's group, who looked at inflammation and general inflammation, CRP, showed it with dietary and behavioral risk factors for AMD, and what she found was that higher levels of lutein and zeaxanthin were associated with lower CRP levels. So again, lutein seems to be able to lower the inflammation status of patients. So we all summarize this, and that's mainly Isaac Elsa's work, who's in the audience and who may have seen these days in this Progress in Retinal Eye Research paper, which was published last year. Okay, now that was the lutein part of inflammation, but how AMD comes in? Well, there's I almost want to convince you that there's also inflammation ongoing in AMD. For instance, this is, if you look at drusen, this is a paper from 2006, and you stain for C3d, C5a, which are complement factors associated with inflammation, then they show up in the hard drusen. Similarly, if you look, it seems that this A2E, there it is again, it can activate complement factors in serum, as has been shown by the Janet Sparrow's group. And this all led to the notion that this inflammation has something, well, is a very important factor in AMD, which led eventually to the very important result that complement is a very important genetic predisposition for AMD. And for instance, if you look at CFH, which this one, oops, here, this is the results from a Dutch group from the Rotterdam study. And you see if you compare non-carriers to heterozygous and homozygous carriers, then you see that you rather be in this group than in this group for your risk of having AMD. So when I started in this field, well, in 1992, I was told AMD, 20%, that's genetic. And that went on until 2005. And then this came out, and now we think it's maybe more than 80%. So it was really a paradigm shift as far as I'm concerned. Okay, so here is where it gets tricky for me. This is the complement pathways. There are 3 complement pathways. And it seems that the classical pathway, the lectin pathway, and the alternative pathway, which eventually all end up in the cell lysis. So they, there's a kind of membrane attack complex, which is the end product, which gives rise to cell lysis. And what seems to be important in AMD, that's the alternative pathway. And I've drawn it here in another graph. And here you see the CFH coming up. And this is a kind of negative control. So you rather have much of this, because if you don't have too much of this, then this loop gets out of hand, and you get a lot of this MAC, which you'd rather not have because of this cell lysis. Okay, so how can we combine the two, have lutein and AMD, and do some research on this? Well, then there's another notion. If you look at AMD, it's not a local effect. There seems to be a sort of kind of chronic inflammation ongoing. And if you look in the sera of AMD subjects, as was shown by Hendrik Scholl's group some years ago, then you see there is a systemic complement activation also. Markers which are very specific for this alternative pathway are elevated in AMD subjects compared to controls. The ones I indicated in yellow, these are the ones which are significant, or these are ones which are significant, but these are also the ones which I'm going to which we have looked at, and which I'm going to discuss in the next slides. This was confirmed, by the way, by a paper from the Dutch groups in Nijmegen. So what can we do? Well, we did have a trial which went on several years ago, looking for lutein and beneficial effects on visual function. I'll show you some results later on. But we had some blots in the freezer, and we thought, well, if lutein has some anti-inflammatory effect, let's just go back to these bloods and look whether we can see differences from baseline to endpoint after a year, whether there are changes in these biomarkers in the placebo group compared to the Lutein group. Okay. Maybe I'll discuss this later. So just to continue, this is the actual intervention trial we used to it. But since I hope I have some spare minutes extra, I'll just read you through the results of this trial. It was a prospective 1-year trial. Here it says, looking for lutein, whether it has a beneficial effect. Well, as other trials, we saw also that if you look at the lutein group, macular pigment goes down, whereas it does not in the placebo group. And here's the change in macular pigment optical density in the one group and the other group. And well, this is results which you would expect, which you may not expect is that you also see beneficial effects in visual function, as others did. This is visual acuity in logMAR, so a decrease means an improvement. And here it's maybe better to look. You see in the lutein group an improvement in visual acuity, and in the placebo group a decrease in visual acuity. And the difference, this is significant. So you rather have lutein to have a small but significant improvement. Then we also looked at rod function. Everybody knows AMD is a foveal disease, but as Cusio puts it in a paper which I read a long time ago, spare the rods, save the cones, or save the rods, spare the cones, I never know. But anyhow, the idea is rods die out in huge numbers before there is a foveal thing to be seen. So if you could spare the rods, decrease this process, then you may be able to also spare the cones, the foveal part. So in order to look whether lutein has some beneficial effects on these rods, we looked at dark adaptation. Dark adaptation. And as was pointed out yesterday, dark adaptation is a very, it can pick up very easily differences between normals and AMD subjects. So we looked at the rod slope. We had a model to model this rod slope. And again, we saw some beneficial effect, so an increase in rod slope in the lutein group and a decrease in the placebo group, which is significant. So again, you benefit from lutein, as we heard this meeting many times. So back to the serum results, but that's what I want to talk about with results from this trial, which gives us positive functional benefits. So we looked at several markers, CFD, C3D, C5a, and eventually the membrane attack complex, which are very recent results. And the idea is this complement factor D, that's a kind of positive rate-limiting factor influencing this cycle, like CFE being a negative. So you rather have not too much of this, because if you do so, then you speed up this process and you end up with too many of this, which is not that beneficial for you. So we looked at these three, CFD, C5a, C3d. These are the baseline characteristics. But what really astonishes was this. And I still may even not believe this. This is time in months, and this is the relative concentration. So we all normalize it to 1 at baseline. These are the placebo group, and this is the relative concentration. And what you can see is that after 12 months, we had a 50% decrease in this marker, in this chronic inflammation marker. And accompanied with this, and that's why we think, well, if you decrease this complement factor D, because of its rate-limiting positive control, you would expect that further downstream in this process, things go down also. And indeed, we do see decreases in 36% in this C5a. We do also see a small increase in C3d, which we attribute to the fact that C3d should go down, but it sticks to the surface. It is in this complement process. So that's why we think it's not that high as this this 36% and this 55%. By the way, it is significant, and this is a significant difference between the placebo and the lutein group. What we also looked at is change in complement factor D along this line, and change in C5a, and again this correlates significantly. So again, showing that this idea of decreasing CFD, and by that slowing down the alternative pathway makes sense. So in the meantime, these results I hope will be out very soon. But we went on, and we have also looked at the final membrane attack complex. And I had no time to make beautiful graphs of this, so this comes directly from SPSS. And we see the same. We see a decrease in the lutein and an increase in the placebo group, which is significant. And if you look for a change in C5a, then this is directly related very significantly with a change in the membrane attack complex. So how come? Here is this scheme again. So the idea is we have lutein in one way or another. It can influence this complement factor D, and as a result, downstream things go for the better. But how can lutein influence this? Well, this complement factor D is also known as adipsin, and it's produced in adipocytes. So maybe that's a pathway, because we all know that lutein is stored in adipose tissue. So we thought, well, maybe that's the mechanism to look for why this complement factor D is decreased by adding lutein. So we went looking around, and happily for us in Maastricht, which is where I'm working, another group had a adipose cell line, which they did study. We went to them, and we got the cell line. So it's an adipose cell line, and we started this experiment. We cultured several of these cell lines. Some of them we just followed. That's the blank. At some we added lutein in a huge amount, well, not huge, in a physical plausible amount. And as a control, we had also not only the blank, but the solvent only, which we solved lutein in. And the idea then would be that this adipose cell line would secrete this adipsin, this CFD, and if you would add lutein, you would diminish this. So what are the results? These are even fresher. I made them yesterday evening out of SPSS, so these are really, nobody has seen them yet. Even I did not see it. So here they are. These are the different wells, and you compare them one-to-one in some of the... So, for instance, look here. This is these black, if you can see the blue circles, it goes up. This is time, by the way, 24 days, 24 hours, 48 hours, so 1 day, 2 days. So the more CFD is secreted, but this is lowered by adding lutein. You're the same. It goes up, but it's lowered by adding lutein. So I try to summarize all this in this graph. This is the result at 24 hours, 84 hours. So you start off with nothing, and then it's secreted in a certain amount. And of course, this goes on at 48 hours. And this process is apparently slowed down by adding lutein. It was good for us to have the TFH in because of control. You see that TFH, one way or another, adds up, speeds up this process. Another way of looking at this, these graphs, which is more or less the same. This is the control, and the rate is going down. And this is the TFH only. And here is the output of the statistical analysis from SPSS. So what does it tell you? Lutein, which is effectively telling that at this point there are some differences again. And this is looking at 24 hours. So already 24 hours, there is some difference. That makes sense because they all come from the same origin. There's a time effect, obviously, because they all decrease. But the time effect is, depends on which group you're in. So this is definitely increasing much slower than the other groups. So this might be a mechanism how lutein can influence this CFD production. Okay, So in the meantime, many, as far as we know, medical trials are ongoing, looking for exactly this. Can we slow down this complement system by using drugs? And the message of this talk is, you rather use lutein because it more or less does the same. And it's not a drug; it's a supplement, which makes things much easier. So to conclude, lutein supplement significantly decreases circulating levels of the complement factors CFD, C5a, C3, and the final membrane attack complex. I hope that I've convinced you that this may be mediated by these adipocytes. And of course, this offers then a simple method to control the inflammatory pathway. Of course, independent confirmation is needed, but I think many in the audience here could do this in the upcoming months because they have the same bloods in the freezer. So let me then end up with thanking my collaborators, Yuan Tian, Aise, who you've met, Rob van der Veen and Maria Macular, who did all the work in the Lutein trial, and Ian Murray, he's in Master in Crime with me doing all this research, and we got some financial reports from de Stichting Nederlands Ongekundig Onderzoek, Blinden en Slechtziende, Macular Degeneration Foundation, and the lutein at that time was given by us by Cognis. I'm happy to answer questions. Thank you.
So the paper is open for discussion. Any questions?
It's very interesting to think about the fact that this is an adipose related factor. I'm wondering what your thoughts are about the fact that the accumulation is occurring in the eye, the neural accumulation, and do you have any thoughts about whether these same pathways are in effect in the neural tissues?
You mean that these adipose adipocytes are produced in the neural?
No, well, no. Of course, adipose isn't in the neural tissue, but I'm wondering if some of these complement factors are also active in the neural tissue in the retina.
They are found in drusen, for instance. So in the retina itself, there's this complement activation. I mean, that's the idea of how IMD is working. But there's also a chronic inflammation ongoing, and that's what lutein seems to be working on also. By the way, this may also be a way to understand cognition and brain-related Alzheimer's disease, because there's also some inflammation ongoing.
And I think that for carotenoids, astaxanthin has been associated with inflammation or reducing inflammation. But I have a question related to the dark adaptation. This is a little bit off, but it's come up several times during the meeting, and macular pigment density or lutein and dark adaptation being used. And of course, what I think of in the international nutrition side is, vitamin A deficiency. And is there any kind of relationship between lutein, zeaxanthin, macular pigment, and the retinal pathway for
the visual cycle.
Visual cycle, yes.
I did a lot of research in looking at visual pigments way back, and also looking at whether it's decreased in the speed and the amount of visual pigment. At that time, we did never look at that lutein. And the lutein is the way we think it works is in the outer segment of the rods. So it makes sense that dark adaptation is somewhat influenced by, or it can be beneficial to have a lot of lutein. But never, as far as I'm aware of, nobody looked at visual cycle and lutein.
Yeah,
Maybe we should.
And the group here is looking at the carotenoids, and the people who are doing the vitamin A work aren't looking at the lutein. I don't know whether there's anything that would cross over there that would be of interest.
It would be nice to do so. I see some, maybe.
Related to that, Neil and Toss, is Johannes van Lintig's work, where he shows that decreased levels of vitamin A change gut expression of the transporter protein ISX. And so if you have a low level of vitamin A, you can't then transport the beta-carotene in to raise the vitamin A level. So you've got kind of a negative feedback loop between this transporter and vitamin A levels. So that might be connected as well with lutein transport.
By the way, you need a lot of vitamin E deficiency before you will notice this in visual pigment.
Yeah. And that's why
Yeah.
I'm a little surprised that you're seeing this change in dark adaptation with visual pigment.
These are the results. That's the only thing I can say. Yeah.
Yeah, I would second, Neil, that there are a lot of potential links that we don't understand between lutein metabolism and vitamin A metabolism. Also, a predictor of lower macular pigment was a common variant in RPE65, which is associated with increased activity of the visual pathway in the eye, which is thought to increase oxidative stress. But also there's a group that found that vitamin A supplementation slowed AMD. And we're finding BCMO1 to be a gene variant associated with lutein too. So I think there's some interrelationships along with the absorptive relationships that we still have to understand.
Have you measured CRP or interleukin-6?
We didn't. Yeah, we didn't find any changes in CRP, which is more a chronic inflammation ongoing. Whereas these are very specific for AMD. So there were no relations with CRP. So CRP levels, they stayed equal.
They had low CRP values to start.
Yeah. There were no. Yeah. So there was no general inflammation ongoing, at least. And this, by the way, these were early AMD subjects. So you expect them to have a little bit higher in between the normals and the AMD subjects from Scholl's paper, and indeed they were. So we were in between the baseline values between Scholl's, the normals and the AMD subject of Scholl.
A question?
I'm not sure if that fits in that talk, but we did a recent study where we actually looked at healthy participants who were at high risk for AMD and were homozygous for CFH, and there was no correlation with macular pigment optical density. So I have to think how this fits into your talk, but and I know, John, you did a study where you looked at, they also looked at...
It's always hard to look at cross-sectional data and compare it with interventional data. As we heard yesterday from Emily Chu, cross-sectionally you find result DHA positive results, but if you did an intervention trial, it's hard to pick up. So it's always hard to extrapolate. Yeah.
Yes, question. Just the first floor.
Did you do some genotype in CFH?
Not yet. We are busy doing this. Yeah.
Other questions? I have just a question from a clinician. Do you think that it could be useful to use lutein in exudative AMD? I mean, you know, ophthalmologists like to make a lot of intravitreous injections.
Yeah, I think so, yeah.
Yes, my question is, do you think that it's better to give some oral supplementation, or maybe one day we could add in the intravitreous injection some lutein?
The last I don't know about, but I guess it makes sense to add lutein to the diet of people having these intravitreal injections, because then you attack the problem from two sides. You do this anti-VEGF, but at the same time decrease the inflammation by adding lutein. And maybe in that way you could, instead of having an injection each every month or every 2 months, longer that period, where it's may benefit the patients.
That's interesting, because most often we say that it's too late for supplementation when people have
I don't
new
think
results.
so. No,
okay.
That would be definitely would go for this. Yeah, I'd give it a try.
Thank you very much. So, thank you. And